and we will just have to ensure and just verify if it is actually gone live. So let us just do that one time and ensure that everything is going smooth inside that. And I think we've started streaming, but let me just verify it one time more. All right. And yeah, so I think we are streaming live, and there is no problem in that. So we have started streaming onto YouTube, and we will start off the session. So in order to start off the session, I would just start to share my screen, and I would ensure if the screen is getting shared or not. And I think the screen is getting shared. All right. So because the screen is getting shared, we can just go on to my notes and we can start off with the entire chapter, right? And that is going to be on semen analysis, understanding of the basics. Correct? Can we see this on YouTube? Yeah. Right. So we can see everything, right? So in order to understand the semen analysis, what is very, very important is to understand the entire basic anatomy and physiology of the sperm, right? So as we all know, here in the males, we have the testis, and through the testis, you have a lot of seminiferous tubules inside, it's divided into compartments. And through this, you have the vas deferens, which is going to come out. The vas deferens is going to lead into something called as a seminal vesicle, which is then going to lead into an ejaculatory duct, which is going to travel through the prostate, and it's going to then come out, through the penis, and that is going to come out as a seminal fluid. All right. So when we look at this particular thing, when this thing is going to come out as a seminal fluid, what we are going to try and test in our semen analysis is the seminal fluid. All right. So let me just draw everything very quickly for everyone. It's going to be the prostate, as I mentioned. It's going to be the seminal vesicles. All right. It's going to be vas deferens, and it's going to be testis. Correct. Now, out of the seminal fluid which we are going to analyze, what is important is less than 5% is actually going to be sperms. All right. In the entire seminal fluid, less than 5% is sperms. Rest is everything else. It can be fluid from the seminal vesicle. It can be fluid from the prostate. It can be any additional fluid. It can be some fluid coming in from the vas deferens and the remaining fluid from the urethra. That is something which is important for all of us to understand. In order to make it slightly more descriptive, now let's try and understand the entire pathology one by one. Okay. So let me first draw. If I were to draw a testis like this and then, tell you that, it is divided into multiple compartments, and let me draw one seminiferous tubule inside, correct? You can see that, let's say this is a seminiferous tubule. I am going to expand this seminiferous tubule. So we are going to magnify this seminiferous tubule. So let's draw two of them. This is number 1 and this is number 2. All right. So we have two seminiferous tubules. Remember, the testis, has something called, which is a very interesting thing, the testis has something called as a blood testis barrier. Right? No vascular supply directly goes inside the testis. I mean, inside the seminiferous tubules. All right. And in between the blood vessels, you also have something called as Leydig cells. Inside the seminiferous tubules, so if I were to draw something inside the seminiferous tubules, you have something called as Sertoli cells. Sertoli cells are probably the ones who are forming the basement membrane here. All right. So these are your Sertoli cells, which will form the basement membrane. Okay. And you all know Leydig cells are going to be acted upon by LH, and they are going to produce testosterone. Sertoli cells are something which really like the FSH. Okay. And Sertoli cells are predominantly responsible for your spermatogenesis. Correct? No? So you know all these things. Right. Now, let's go one picture down and let us magnify a Sertoli cell. So this is a Sertoli cell which I have magnified. Correct? Is my visible? This is a Sertoli cell which I have magnified. So what typically happens is at the basement membrane, you have spermatogonia. Do not actually try and study this in great detail as a part of this lecture. Obviously, I can tell you many things, but not right now as a part of this lecture, right? So what do you have? You have the spermatogonia. Just remember this as a basic, all right? Now, once you have a spermatogonia, what's going to happen is that the spermatogonia initially is just like any other cell. It begins selective transformation to form a sperm, which is very, very important. So just like every other cell, this guy has a nucleus, which I have demonstrated. Along with the nucleus, it has mitochondria, right? So I'm drawing mitochondria in blue color, okay? Then it has something called as Golgi bodies. So I'm drawing small Golgi bodies here and there, right? Now this is present inside the spermatogonia. It is a round cell, haploid, right? What happens is as and when the maturation occurs, you will begin to notice the cell changes its architecture a little. You can see now what's happened. Now it has changed an architecture a little. Correct, no? Nucleus has shifted slightly upwards. Mitochondria have got arranged slightly close to the place where it is forming the tail. And these Golgi bodies, which we mentioned about, no, they are going slightly into the cranial aspect of this cell. So that this is a transformation which begins to occur. Slowly and steadily, there is going to be more transformation. You will notice one thing as a part of this development. Okay, you are going to notice one very, very important thing as a part of this development, and that is the cytoplasm is going to shrink, right? A lot of cytoplasm is going to shrink away. Nucleus gets cordoned off in the top. You have the Golgi body, which have accumulated here near the cap, forming something called as an acrosomal cap. You have a centriole here. All your mitochondria have got shifted inside the middle piece. All right. And then there is a tail. And obviously, after this, there is the final delivery of the sperm, which is going to happen, where it's going to become slightly more compact. You know, it's really going to become more and more and more compact, right? So it's going to form something like this. The mitochondria is going to expand here, and then this gives rise to the formation of a tail. Inside the mitochondria, as I have mentioned, you are going to have the middle piece, which is packed with mitochondria. You are going to have the head of the sperm, right, which is packed with the nucleus, very limited cytoplasm. And then you have an acrosomal cap. Obviously, all these things, you know, are going to take its own sweet time to mature. So you can see what happens is as we move up this journey, you know, as we move up the ladder in the Sertoli cell, the first thing you must remember is that there is something called as cytoplasmic reduction in the sperm. This is something which is absolutely mandatory, correct? It gathers a completely different structure. Now, because there is a reduction in the cytoplasm, you are going to face all the types of problems. You know what is cytoplasm and how is cytoplasm going to help you? Your cytoplasm is going to be helping you in correction and defense. Correct? Defense from what? For the sperm, it is something called as free oxygen radical. Correct? No? It needs defense from that. Correction means any form of anatomical correction. So now that means if there is a testicular cause, all right. So what I mean is this, see, if there is any form of testicular cause of having reduced sperm production, if there is a testicular cause of having defective tails in the sperm, and if there is a testicular cause of having defective shape, right, that is inherent, you can't really change this. In that type of a situation, please remember that a testicular cause is going to be very difficult to correct. All right. This is something which is difficult to correct. So let me just put it for you that it is going to be something which is difficult to treat. All right. And predominantly options are going to end up with something called as assisted reproduction. Remember, in all these situations, the hormonal profile is going to be almost normal. That means you are going to have an almost normal FSH, almost normal LH, almost normal testosterone, almost normal estrogen. All right. In this entire profile, when you have oligo, astheno, teratozoospermia, okay, which is of a testicular cause, your hormonal profile will be almost normal, and that is going to be something which is difficult to treat if it is a testicular cause. Correct? Now, let's go one slide above, and then we will focus only on interpretation of semen analysis. So if you understand this, no, the entire semen analysis is going to be an absolute cakewalk for all of you. Correct? Once again, let me draw the testis. So here is the testis. Correct? Here you have the vas deferens as I drew with the seminal vesicles and the ejaculatory duct. Correct? No? Now, let us look at everything which is something called as a post-testicular cause. Okay? Post-testicular causes. See, I'm going to come to pre-testicular causes. So I'll just tell you pre-testicular causes, no, are going to be predominantly related to the brain. So let me just tell you that it's going to be related to the hypothalamo-pituitary axis. Okay. And it is easily correctable. This is something which is easily correctable. So we are not going to discuss that because the subset of that case is very less. So post-testicular causes are all the causes which are going to affect your sperms once the sperms have been produced and have gone out of the testis. So once they are in the vas deferens, seminal vesicles, ejaculatory duct, prostate, this is all going to be your post-testicular causes, or any form of post-testicular causes which has caused some problem, okay, to any form of hormones. So what is that? One of the most common things which people miss out in our country is hyperprolect anemia. Okay, hyperprolect anemia is absolutely correctable. It is something which can cause alteration, to be honest, reduction in FSH and LH, which can cause reduction in sperm production and sperm motility. Second, very common in our country is hypothyroidism. Remember, hypothyroidism is not just in women. Hypothyroidism and hyperthyroidism both affect male partners as well, and they can also cause a reduction in the total amount of sperm. So both of them can cause severe oligospermia when you are diagnosing them. Third most common in our country is obesity. Obesity is something which causes alterations in hormonal level of FSH by causing increased peripheral estrogen. Okay, and obesity is something which is extremely correctable cause of post-testicular problems. Fourth, if I may call and if I may label it this way, then it can be any form of infections. See, any form of viral infections in the system, any form of inflammatory causes. So let me just call it inflammatory causes and infection. Now, this could be anything. This could be autoimmune, this could be infective, this could be viral, this could be bacterial. All of them are important causes of causing temporary. They are important causes of causing temporary alterations in your sperm parameters. They are temporary alterations in sperm parameters. Normally, these things are going to become okay in a span of 4 months. A typical example is COVID, or let me just call it post-COVID azoospermia. That is something which is very common when we saw in COVID times, and patients who were given nothing became absolutely okay, right? Fifth is any form of systemic causes, especially hypertension in our country. That is something which is very, very common, very commonly missed out. Diabetes mellitus. You're going to find males who are having these type of problems are going to end up with even more amount of severe problems. All right. So that is something which you have to keep in your mind. Correct. Sixth, smoking. drinking, stress. Remember, we lay a lot of stress on these three parameters, thinking that it is these three which cause increase in free oxygen radicals, okay, in the system. Now, actually, that is not correct. Of course, they do cause an increase, but all the other parameters also, infections especially, cause a huge increase in free radicals. Obesity can cause a huge increase in free radicals. And when I talk of free radicals, I also want to talk of one last thing, which all of us must remember as far as the testis is concerned. From the testis, there is something called as a pampiniform plexus of veins. Especially on the left side, this ends up in the renal vein, and through the right side, this ends up inside the IVC. All right. If you have a form of palpable, this is something important. The word important here is a palpable varicocele. All right. If you have a palpable varicocele which has caused oligospermia in absence of everything else, all right, this is a very important point. If it has caused this in absence of everything else, then a surgical correction can give you approximately 30 to 50% benefit. Probably that is the only indication of doing varicocelectomy. Okay, that's the only indication. Apart from that, I believe there is no other indication for doing varicocelectomy, and I'm telling you this because we do a lot of varicocele surgeries. With all this in mind, what I have just told you, let us just focus on semen analysis. Now just see how easy, if you scroll through the slides, it is going to become to interpret semen analysis. Obviously, we need a WHO standardization and the basic points which everybody, so here we are going to discuss only the basics. So the basic point which everybody must remember is that volume to be more than 1.5 ml. That is an important basic point. Correct? So what can affect the volume? Just see this now, right? So the first place where the volume can be affected is something which is very rare, when instead of the sample coming out from here, it went up. Correct? That is something called as retrograde ejaculation. That is one of the most common causes. But in practical life, the most common cause for having a volume problem is something called as improper collection. That is the most common cause in our country. A person, 80% of the sperm samples spilled outside the container. That is the most common cause of having a volume problem. Persistent volume problem, please try to rule out retrograde ejaculation. Persistent volume problem, please try to rule out diabetes mellitus in our country. Okay, that is something which is important, and that's the only thing which you should know as far as the basic of that thing is concerned. The second most important basic parameter which you should remember is the sperm counts. Now, please remember, sperm count should be either more than 39 million in the entire sample, or they should be more than 15 million per ml. Now, it's very important to understand how the counts are measured. So the gold standard to measure count is something called as macular chamber. Now, I know 99% of the laboratories where you refer, they do not do it on a macular chamber, but it has to be done on a macular chamber. That is one of the best way to report it. Okay. You want to go really one step ahead, then you can do something called as computer assisted semen analysis. But at the moment, it is not gold standard. Okay. At the moment, it is not the gold standard. Obviously, in the future, it will become. Any count of a male partner which is considered to be less than 15 million, all right, so between 10 to 15 million, if I may just put it, okay, is considered. Anything less than 15 is oligospermia. But if you look now, then less than 10 to 15, you can convert it into mild. Less than 5 to 10, between 5 to 10, all right, it's going to become then severe. Mild to moderate is here, that's going to become severe, and less than 5 million is going to be like really, really severe ones. So what is important for you to understand is that this category, no matter what you do, no matter what the cause is, this category only needs either IVF or ICSI. Correct? This category, 10 to 15 million, is going to have excellent response to treatment. And I will come to the treatment in a very short while, or probably I'll take a next session on treatment. So this is going to have excellent response to treatment. Okay. Now, after you finish the counts, what is again very, very important for people to look and understand is motility. Now, progressive motility or rapid progressive motility more than 32% is fine. Total motility more than 40% is fine. Now remember, motility is one thing. No, if you study motility, see, motility is here. Formation of the tail, this part is motility. See, this when you study motility, you must always have a repeat sample. You must always have a repeat sample, preferably from a different laboratory. All right, please do that. That is going to give you wonders. Remember, examination of time of the sperm should ideally be between 20 to 35 minutes. Okay, a lot of times in laboratories where manual reporting is done after 1 hour, which causes sperms to die inside. That can cause an artificial reduction are more than 4%, then it is fine, right? But how do you study the normal forms? The best way to study morphology is going to be a testicular cause again. It's going to become very, very difficult to actually end up treating morphology. All right, unless there is a post testicular cause, it's going to become very, very difficult. In our country, people are also really worried about something called as pus cells, and pus cells, remember, ideally is going to be somewhere between 2 to 5, but sometimes debris gets reported as pus cells, so that is something very important. Sometimes what is going to happen is that again it is going to be a collection error. Again, it is going to be a collection error. So please, in cases of pus cells, sample has to be repeated, and it's very, very simple. You can ask the gentleman to just retract the foreskin, okay, and just clean the penis for approximately 2 or 3 days. Just routine soap, routine water, very mild solution of betadine if you want to give, and then repeat the sample after 5 days or whatever, and you are going to see the pus cells, which are, let's say, 20 to 30, would have then got converted to pus cells of 2 to 5. So it is a real common thing. But if it is a persistent problem, then remember, the patient is going to also complain of painful ejaculation, and you must remember to do something called as per rectal examination, okay, PR, and you must do a semen culture if it is indicated after that. But these are examination points, so probably we can cover it when we have a detailed session on just pus cells. All right, the third thing which people really like to listen about is something called as viscosity of the sample. Now remember, viscosity of the sample is predominantly driven by the prostatic proteins. All right. So if there is a hyperviscosity, if there is a hyperviscous sample which has more than 30 minutes, or let's assume for simplicity, more than 50 minutes of liquefaction time, the best way to treat that is by doing manual reduction of viscosity by lysis. This is something simple. We have a beautiful video of this as well on YouTube, and you can use this sample to then perform your IUI, ICSI, or whatever you want to perform. But manual reduction of viscosity is something which can be done. The agent which we normally use with this is HIPIS, which is simply a buffered solution. And as I've said, we have a beautiful video on this, and you can probably try to learn this if in case you are interested. Okay. So with this now, we are covering all the basic parameters of semen analysis, which you probably need to keep in mind as a basic practitioner of fertility. I want to add one very, very important line. See, a lot of people tell this, that, okay, if there is a post-testicular cause, what is the treatment of choice? The treatment of choice is to give antioxidants. Correct, na? This is the treatment of choice. antioxidants to be given for, let's say, 3 to 4 months. Now, I want to tell you some things about antioxidants. One is they are well marketed. There is no question about it. People really find wonders in them. So Cochrane 2022 has clearly demonstrated, all right, that it has something called as in subfertile men. Okay, in subfertile men, the word used is may benefit. So what they did, so I've gone through a lot of literature on that and how they studied it. So they studied approximately 10,000 men, and they found that if you give no treatment, okay, or if you give antioxidants, correct now? If you give antioxidants. So if you give no treatment, then out of 100, you're also out of 100. Out of 100, 15 to 17 people are going to become pregnant if you don't give any treatment to them in a span of 3 to 8 months. And if you give treatment, same, in a span of 3 to 8 months, you are going to have approximately 20 to 30 people who are going to become pregnant. Now, this they have proven to be statistically significant, but you really know how well the research works. So please be very careful when you are giving antioxidants. Antioxidants is something which is available not just in allopathy. You have beautiful preparations in Ayurvedic medications, all right, for antioxidants. You have some preparations in allopathic medications for antioxidants. But remember, in my humble opinion, what I have found over my career is that if you prescribe Ayurvedic medications, they have slightly better outcomes as far as antioxidation is concerned for the sperm sample. All right. I think this 45 minutes or maybe 35 minutes, which I've spoken, will give you a wonderful brief overview as far as basics of the sperm fertility, basics of the semen analysis. And whenever you have any further things which you need to look as far as the basic semen analysis is concerned, I'm sure this type of a session is going to benefit you. We are going to take further sessions on advanced semen analysis. Probably we are going to start this series where we are going to be focusing only on viscosity, only on density, only on swim up technique, only on double density and all these things. And I'm sure it will benefit you. With this, we will be concluding the session here. If you want to have any questions, you can ask them on WhatsApp. We shall be very happy to answer you. Thank you so much for joining us. And this is now available on YouTube. So you can watch it as many times as you want to watch it. All right. I hope all of you have enjoyed, and thank you so much.